Welcome to You and Your Health. I'm your host, Dr. David Bertone. It's been several months since we've had a show, and we've excited to bring back some new topics this season. We're going to start today with a topic on regenerative medicine and minimally invasive orthopedic procedures. Our guest today is Dr. Daniel Savarino. Dr. Savarino is a fellowship-trained sports medicine physician. He's also certified in musculoskeletal ultrasound and is the owner of Apex Sports and Regenerative Medicine located in Tinton Falls. Dr. Savarino, welcome to the show.
Hi, thanks for having me.
So tell us about your background and how you got involved in regenerative medicine.
Sure. So I initially trained in family practice, and then I went into sports medicine after that. Through sports medicine, I started getting into the regenerative field through working with different doctors that had been doing that at the time. And then after my training, I started getting very involved with ultrasound, and I went on to get my certification in ultrasound. And then I've been doing it ever since.
Great. So tell us, what is regenerative medicine? Some people may hear about it on the news, and it's in vogue now with certain orthopedic type problems. What is actually regenerative medicine?
Sure. So regenerative medicine is using different parts of your body, like your blood or stem cells, to help heal areas that otherwise could not heal on their own or just did not heal on their own for whatever reason. A lot of times it's due to lack of blood supply, like your tendons and ligaments don't really have a great blood supply. So if they don't heal on their own, we can put parts of your blood that help to heal there, and it actually helps to remodel and heal that tissue.
Okay, so one of the techniques is called platelet-rich plasma therapy, or
Yes.
better known as PRP. What's involved in that process? And tell us a little bit about the mechanism of healing and why you would use that. Sure.
So the platelets are the parts of your blood that cause healing. So, probably the most common example that someone would know is if you cut your arm or your knee, you notice it starts to clot and then it heals. It's your platelets that cause that. So basically what we're doing is we're putting a high concentration of platelets into areas that have not healed. So the way we do that is we draw your blood just like we're doing blood work. Then what we do is we put that blood into a centrifuge. It spins the blood by weight. It separates the red blood cells and the white blood cells, which we really don't need for this process, and it concentrates the platelets, which we draw off and inject. The platelets themselves are only about 6% of the blood, so we concentrate it to 5 to 10 times that amount so that we get more platelets to an area that needs to heal.
Okay, so you take the blood, you gather all these platelets, and then you inject them into a location that's not healing?
Correct.
Okay. And so what's involved? Is it just a plain injection, or you do that under guidance, or how would you find the spot?
Everybody does it differently. I believe that if you're not doing it under guidance, you're not doing it properly, because you don't know if you're going into the right spot, So with ultrasound, you can actually see the tissues and you make sure you put it into the right place. Also with things like tendon and ligament injuries, once they become chronically injured, the tissue changes, and you want to put it into that area where the tissue's changed, because there might be good tendon around that, and if you're not putting it in the right spot, you're just not going to get the healing that you're looking for.
Got it. And so what are some of the conditions that you might use this for?
Sure. So PRP can be used for most orthopedic issues, but most commonly it's chronic tendon injury, like very common in tennis elbow. I would say that's probably one of the most common areas you treat, but you could do it for rotator cuff and jumper's knee, patellar tendonitis in the knee, Achilles tendonitis. It's used for plantar fascia. You can use it for chronic muscle injuries too, because while muscle typically has a very good blood supply, when that area gets injured, sometimes that area becomes a little ischemic or loses its blood supply, so you're going to put those healers in places where it hasn't been getting to in a long time. It can even be used in arthritis. It hasn't really been shown to grow cartilage in arthritis, but what it does is it changes the inflammatory environment of the knee or the hip, and it reduces pain and actually can give you more function.
Awesome. So there's also another procedure that you do that's regenerative medicine. It's called stem cell therapy. And what is that, and how does it differ from PRP?
Yep. So our stem cells are are in our body naturally. What they are, there are precursor cells, meaning it's a cell that can become other types of cells. So there are what they call hematopoietic stem cells, which can become your different blood parts, like your red blood cells, your white blood cells, and your platelets. And then there's other types of stem cells that become cartilage and tendon and ligament. So basically what you do is when you put those in areas of injury, it will become the area that's injured. So if you put it into a tendon, those stem cells will actually start becoming tenocytes or tendon cells. And stem cells basically can replicate themselves, so they can keep producing more of themselves. They can turn into different types of cells, and they last a very long time. When I do my stem cells, I also mix them with platelets, because there is a good amount of evidence that the environment that the platelets create helps the stem cells grow more and actually live longer.
And where do you get the stem cells from? Is that the blood as well, or is that at different parts of the body?
Sure. So peripheral blood does not have a high concentration of stem cells, so it's not a great place to get it. Where you typically get it is the bone marrow, where you find the highest concentration is actually in the back of the hip. It's a place called your PSIS. You can also get it from adipose tissue, so from some fat tissue. And now what they're doing is also you can get it from umbilical cord blood. So people can actually donate their cord blood now, and that can be injected as well.
So can you, you can get it from yourself, but then you can also get it from a bank, say, stem cell bank? Is that something
So there are
that's common?
companies that actually, it's donated from a healthy cesarean birth. The mother donates the cord blood. It's put through a process where the mother and the baby are tested for any kind of disease, and then they put it through a filtration process so that it won't reject, like if you just took someone's cord blood and injected it into somebody else.
Wow, that sounds pretty exciting. Now, you're saying that the tissue will grow very similar to where you're putting it. So is that beneficial for things like meniscal tears in the knee or cartilage injuries?
Yes, so there is actually some studies that actually show a regeneration of the meniscus when you put stem cells in that area. Stem cells are also very smart, so if you put them in an area, it will actually be attracted to the area of injury. They know where to go.
So just to recap, the difference between the PRP and the stem cells, one is blood, one is cells that come from kind of the bone marrow. Sometimes you combine the two. The stem cells kind of will regrow similar to the tissue. The PRP will grow more of like a scar tissue, or how will that grow in the area?
So the PRP in certain tissues will actually help to remodel and regrow that tissue, because the way the PRP works is they have a lot of growth and healing factors in them, your platelets. And the other thing it does is it signal calls. So it sends chemical signals out to the tissue to bring other cells in. Actually, we do have some stem cells all over our body, and the platelets, when you put it in that area, will call those stem cells to come in and actually help heal. It's not anywhere near the concentration as actually taking a concentration of stem cells and putting it right in that area, but you will get some stem cells that come into that area as well.
Now, will you typically see the patient that has chronic injuries for this? I'm assuming it's not something that's an acute first course of treatment, I would think, correct?
No, because actually the way platelet-rich plasma works is it's actually trying to stimulate the acute phase of an injury again.
Okay.
Because your body will normally give that reaction, and then all those cells come in and they help heal it. But for some people, that just doesn't happen.
Okay.
Some people just don't heal well. Sometimes it's an area that just doesn't have a great blood supply, It's typically not used acutely, and you want to try the easy stuff first, because even though it's very minimally invasive, it's still a needle. You still have to draw people's blood. A lot of times you ice it and you give anti-inflammatories and you do physical therapy. People get better, but there's a large, there's a subset of people that don't, and for that, the regenerative therapy works really well.
So now when you're considering which patients are appropriate for this, is there a set or a group that's not appropriate, number one, and then is there an ideal group that it works on?
So it works for most people. So things like your platelets and your stem cells, their function does degrade a little bit as you get older, so it may not work as well, but certainly still works. For stem cells, though, if you're usually over 65 or so, I would recommend probably going the umbilical route as opposed to the bone marrow route, because there's a good amount of evidence that those stem cells just don't work as well. And the umbilical stem cells, you're getting young, healthy stem cells going in there. As far as contraindications, reasons why you wouldn't do it, if someone has to take blood thinners, you really don't want to do it because the way those medicines work is they inhibit the platelet function anyway. So you're going to put, it's not that it would cause harm, but you're putting dysfunctional platelets in an area and you're probably just not going to get the results you're looking for. There are also certain medical conditions, where their platelets aren't functioning properly, or if they have a very, very low platelet count, you might not want to do that.
So people that might be on chemotherapy for something, or maybe diabetics would have trouble with that.
Yeah, and certainly any type of blood cancers, you would not want to put platelets or bone marrow. You risk spreading that to different areas. So.
Now, has the evidence in the literature? We see a lot of athletes going through this stuff, and maybe not as much of the general population. But the athletes do get this, and it's very successful. So what does the literature say? Is there evidence to support this at this
There's
time?
definitely evidence to support it. From study to study, you'll find different success rates. The big problem is right now there aren't a lot of really big double-blind studies. Platelets have been around for a long time, so I'm not completely sure why that is at this point. But there's definitely evidence to support that it does work for many conditions. Probably the best evidence so far has been tennis elbow. Achilles tendon, it's been shown to work really well for. Stem cells, it's been shown to be superior to things like the gel injections and steroid injections. So there's definitely evidence out there that shows that this works.
Now, what about the big question, the cost? Is this something that insurance companies will pay for? Is it something patients have to pay for privately? What's the typical cost of these procedures?
Sure. So as of right now, unfortunately, the insurance companies are not paying for either. I've heard some discussions that they might start paying for platelets for certain things like tennis elbow, but who knows?
Yeah.
But right now, the cost varies from person to person. I've heard PRP being charged anywhere from $500 to as much as $3,000 for one platelet injection. From stem cells, I've heard anywhere from probably $3,000 to $8,000 or $10,000. I think most people you're going to find for platelets are going to be somewhere between like $800 to $1,500, and the stem cells somewhere between like $3,000 to $5,000.
Okay.
Some people will mix it, and some people don't. So
again, there's no guarantees, but the research has been pretty supportive of using them for certain conditions. As long as you pick the right conditions, it could be extremely effective.
Yes.
What about afterwards? After you do the injections of both PRP and, say, stem cells, is there a rest period? Is there a weight-bearing restriction? Is there rehab? Is there physical therapy involved? What do you typically do with these people afterwards?
Sure. So, that's the other thing with these is that there's no universal protocol, so everyone kind of has their own. My protocol is with either I never make someone non-weight-bearing or immobilize them. So if I'm doing a knee, they can walk. I might put them in a brace that has hinges on it so that they could still bend. I usually tell them to don't do anything crazy for about a week. Don't go run a marathon. Don't squat, 500 pounds. But you can go walk to the store. You can do your basic daily routine. I like to start people on physical therapy about a week after, okay? And then I let them gradually just kind of increase their activities after that as tolerated. I think physical therapy is really important for a couple different reasons. One, I think putting the joint or the tendon or the ligament through its natural ranges of motion just helps that tissue heal properly and in the right way. And then I think just as importantly is the physical therapy can pace them. There's a lot of people that want to do 10 times more than they should too fast, and then there's some people that just don't have the confidence and won't do it if they don't get a little push. So I think therapy's great for that.
So it's not a cure-all. It's not the one shot and that's it. You're going to be perfect. There's a little bit of work involved, a little bit of rehab, some precautions. But the future seems to be very promising in using this technique. So when we come back, we're going to talk about some exciting new minimally invasive procedures that can be done orthopedically that could reduce the need for comprehensive surgeries.
Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
Caring for a family member can be challenging and lead to countless questions for them and for you. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving. Everybody has a dream. Mine was to see the ocean. And with a little help, I made it.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Our guest today is Dr. Daniel Savarino from Apex Sports Medicine and Regenerative Medicine. We're talking about the advances in regenerative orthopedic medicine and the use of some minimally invasive procedures now that are revolutionary in the areas of things like carpal tunnel surgery. So Dr. Savarino, welcome back to the show.
Thank you.
So we're going to talk about the micro-invasive carpal tunnel release. This is really exciting. So carpal tunnel surgery is something that's very common, right? Tell us about traditional carpal tunnel surgery and what carpal tunnel syndrome is.
Sure. So carpal tunnel syndrome is a compression of a nerve in your wrist called the median nerve. It's either caused by the nerve itself swelling or a tendon in that area swelling and causing compression on the nerve. So you have an area in your wrist called the carpal tunnel, which is where that nerve and a few tendons go through. And then on top there's a ligament called your transcarpal ligament that keeps that area confined to a certain space. So if there's swelling in that area or the nerve is too big, it will cause compression on that nerve, which will typically cause numbness and tingling in the hand, specifically the first three fingers and this side of the ring finger. And that can also start causing pain as it starts getting worse. It can start causing atrophy of the hand, so your muscles get very weak. That's usually in a more advanced case, but once that happens, it's usually permanent. People will notice they can't grab things as tightly anymore. They start dropping a lot, and it's very common, especially in the way of the world now with computers and phones, and there's just constant motion. And
repetitive hand movements are a common thing, especially pressure on with keyboarding and things, right? So what is typically done from an orthopedic surgical standpoint?
Sure. So orthopedic surgeons, they have two typical ways that they would take care of this. If you've tried the easy stuff again, it's start physical therapy, maybe bracing, and if that fails and they went on to surgery, there's the traditional way, okay, which is usually about a 3-centimeter incision in the palm. Okay, right here. They expose the ligament and then they cut it. Okay. You have to stitch the hand up. It does take about 2 to 3 weeks just for the skin to heal. Then what happens a lot of times with that, because this skin in the palm is very, very thick, it scars. And then the symptoms don't really go away because the scar tissue is now pushing where the nerve was. That scar tissue a lot of times gets very hard and will soften over time, but that could sometimes take a couple months, 2-3 months before you're really actually starting to improve the way you want.
So now you have something called a microknife that you've been using, and what does this involve?
Sure. So again, with the advancements in ultrasound, you can see under the skin without having to open up to see under the skin. So, we can see the nerves, the arteries, the tendons, all on the surface, So now what we can do is, with the really small incision, we can insert the knife. So basically what this does is under ultrasound, you find the area in between the median artery and the ulnar nerve, okay, which is called your safe zone. You numb that area all the way down, okay, and then you make a little baby incision. It's about a 3 to 4 millimeter incision as opposed to a 3 centimeter incision. And then you insert the microknife. So you insert the microknife, it's completely blunt going all the way in, so you don't have to worry about nicking anything with the blade or anything like that. once you confirm your position, you basically push down on this, and what that does is it opens up 2 balloons on the side. And what those balloons do is it pushes the nerve and the artery even farther apart, so it gives you even more of a safe zone.
Okay.
And then you check your position again, you make sure you're all in the right spot, and then basically you just push on this lever and a little blade comes out of the tip here. You cut the ligament very slowly. You're watching the blade with the ultrasound the whole way through to make sure just everything's in good position. And then once it's done cutting, it actually retracts itself.
Wow.
So there's never a sharp moving in the wrist. And then once you're done, you pull it out. You could even use this to confirm that the ligament is severed by just kind of moving up and down. And then you pull it out and you're done. Basically, all they require is one steri strip and a bandage. They can go back to work the following day. There's really no restrictions afterwards because you're really not disturbing any bad tissue. They're sore for a couple days, but you can really do anything as tolerated after that.
Yeah, and I can see probably a dramatic reduction in swelling, right, afterwards,
Yep.
and minimal scar tissue.
Almost none.
Yeah,
Yeah. I mean, maybe just a little superficial scar tissue on top, but that's not going to interfere with the function at all.
That sounds pretty exciting in this area. So now tell us about, as another tool you have, it's the ultrasonic tendon scar tissue removal tool.
Sure.
So we see lots of scar tissue on tendons.
Yep.
And so the common way is to open the joint up or open the tissue up and look at the tendon, and the surgeon would debride it, and then more scar tissue grows.
Yep.
So what does this device do that's different?
Sure. So what it does is, again, it's because of the advancements in ultrasound. You can see underneath the skin. So for something, for tennis elbow, for example, the old way, like you said, was to make an incision probably about this big. You open it up to where that tendon is, and you basically visually pick out all the bad scar tissue. And what that does is it also causes some bleeding there, and that helps the tendon to heal. So what you can do now is you do that all under the skin again. So basically it's the size of an 18 gauge needle, which is something that you typically use for blood draw, so it's not anything big. You make a little tiny puncture, again, about this big. It doesn't require a stitch. You insert that needle under the skin. You put it in the area of the bad tendon, which you can see with the ultrasound. You could see the good tendon versus the bad tendon. You put it in the area of the bad tendon, and what it does is it's connected to a machine that emits an ultrasound pulse. So basically it makes that needle like a little mini jackhammer.
Oh.
And what it does is it peppers the tissue, and you make passes through the bad parts of the tissue. It breaks up. And then the good part about it, as opposed to just using a needle, is it actually aspirates all the bad tissue too.
So it
there's
sucks
not,
it back out.
Yeah, so there's
Wow.
not all that debris sitting around in there afterwards. Because the old school of tenotomy used to be that they used to take a needle tenotomies. They would just take the needle and they just make a bunch of pokes. But obviously this way, with the pulse, it gets a lot more of the bad tissue, and it gets rid of the bad tissue too, which is much nicer.
So could you do this for any kind of chronic tendon problem, or is it limited to certain areas?
It is limited to certain areas just based on size, so small tendons in the fingers and the wrists might be a problem just because they're too small. You can't get in there with it. And also if it's something that's close to like an artery or a major nerve, it's probably not something you want to do. So where it's indicated is for the elbow, for tennis and golfer's elbow. It is indicated now for rotator cuff. So you can clean up a rotator cuff tendinitis, and you can also break up like a calcific tendinitis. So some people get big pieces of calcium in there. Because it pulses, it actually breaks up and sucks out all the calcium,
cool.
which is really
Yeah, that's
nice.
exciting.
Yep. You can
What
use
about the Achilles tendon? Can
Yep,
you do that
Achilles
as well?
tendon, plantar fascia, which is another very common. And then you can also use it for the knee, for patellar tendon and quad tendon, and in the hip for your glutes. And actually it can help clear out like a trochanteric bursitis that doesn't want to go away.
Wow,
So-
that sounds pretty exciting stuff. In terms of the patient selection, again, is there an ideal candidate? Is it better on somebody younger or relatively healthy? Is there significant contraindications to doing these minimally invasive procedures?
So really not. The beauty of it is there's no general anesthesia. So, for certain people that might have like COPD or reasons why they can't go under anesthesia, you don't have to worry about that. You can do this on people on blood thinners, still taking their blood thinners,
Wow.
because it's such a minimally invasive hole. You don't have to worry about a lot of bleeding. You might just have to keep pressure for an extra minute or two, but it's not a problem. Basically, any of these I think the best candidates are people that have tried the other stuff and it hasn't worked, you know. Again, because even for tennis elbow or Achilles, 90+% of the time you do the easy stuff, the anti-inflammatories, the ice, the physical therapy, it's going to get better. But for those 10% of people that just you tried everything and it didn't work, this is a good way to help that tissue heal.
Sounds pretty exciting. So again, after these procedures, is there a particular course of action? Is there rehab sometimes indicated? Is there a specific strengthening or home exercise you might prescribe? Is it depending on the procedure?
Sure. So for the carpal tunnel, really, there's not much. You can really kind of go back to your day. I always just tell you, listen to it. If it's sore, just kind of take it easy. But once it starts feeling better, there's really no restriction. The 10X, the tendon debridement, there's a little bit more of a healing process because you are removing some debrided tendon. It is a surgery, but you're doing it under a really small incision, so there's less complications. But I usually have them take it easy for about 6 weeks.
Okay.
They could do you can weight bear, you can move around, just, no heavy exercise or heavy lifting for about 6 weeks. And then I usually start physical therapy at that point.
Okay.
Just to get them strong again and get them back going. One good thing with the 10X2 is you can, from the last segment, is you can sometimes take out the bad tissue, and then if they're not getting the full response, you can throw some regenerative stuff in there as well to help it heal even more.
Oh, so you can go both directions. You can suck some stuff out and put some stuff in there.
Yep.
Oh, that's pretty exciting. Again, what about the cost of this? Is this covered by insurance?
They are, yeah.
Oh,
So they are
exciting.
covered by insurance. They're all covered. Because those codes, they're the same codes as doing in a carpal tunnel release.
Got it.
They are covered by insurance. Depending on the procedure, it might have to be done in a same-day surgical center just for coverage purposes. But these are things that I've done in the office and can easily be done in the office.
Great.
Yeah.
You don't have it here today. It's an advanced diagnostic technique that you use. It's something called a vision scope imaging. Can you explain what that is? Because when I read it on your website, I was pretty excited to hear about that.
Yeah. So basically, what it is it's nothing more than a needle. It's a 16 gauge needle, which again isn't that big. That's what they would typically use if they were giving you IV fluids, for instance. That needle has a high definition camera attached to it, and that camera you can stick in joints and take a look around. So it has a couple of advantages. One, if I want to take a look, I can do it right in my office, so I don't have to send you for an MRI, wait 3-4 days for you to get in and come in. So I could just look at it and see it right there. I could give you a definite answer. You can watch me while I'm doing it. And the other thing is it is a direct visualization as compared to something like an MRI, which is a generated image, where things are missed. And not often they're pretty good, but about 5% of the time you miss things. I could tell you I had a patient just last week. I did a vision scope on them. They've had an MRI in the past, didn't really show much, just a little bit of arthritis, but he kept getting these big effusions in his knee. So I said, why don't we take a look? So we took a look inside with the camera, and he had a loose body about this big floating around in his knee, which was probably the reason he's having the problems. So, now he's going to get that removed, and he'll probably be much better.
So you can do more diagnostic with this vision scope and not necessarily send for imaging and see it under live action and how it's actually moving. And sometimes the orthopedist would do a diagnostic arthroscopy where they use the scope, but that's that's a big procedure. It's outpatient. And then it's not usually something that's even covered because there's no surgical indication at that point, correct?
Yep. And then the knee, for a knee, that would be like 3 portals that are, about this big compared to 1 portal about this big. And then the other thing that this is really good for is post-surgical. So if people had surgery on their knee, they had some of their meniscus taken out or, ligaments reconstructed, and then their knee's hurting them, a couple years down the road, you do an MRI, it always looks off. So this, you put the camera in, and again, you can just see what's going on. The other thing you can do with the vision scope, which is really nice, is you can inject through it. So you can put things like even cortisone, but you can inject your regeneratives through there as well. So if you see, for instance, a little focal cartilage defect, you can go in there with some stem cells, and you can fill that area in right there and just put it right into the spot.
That's pretty amazing. Yeah. That's great. Well, Dr. Savarino, thanks for joining us.
Yeah, thank you for having me.
Thanks for coming. And you heard today about some new exciting procedures in the world of regenerative medicine and minimally invasive surgery. I'm your host, Dr. David Bertone. Thanks again for joining us on You and Your Health.